extremely high demand. That was true even before COVID. COVID had just accentuated the fact that respiratory therapists are needed, and our profession is expected to grow by 14% over the 10-year period that the Bureau of Labor and Statistics listed, going through 2031. The majority of respiratory therapists work in a hospital or an acute care setting. That's where most of us work. Now, there are some of us who work not in a hospital setting, like an educational institution. There's others, and we'll talk about that when I get into chapter 2. Where else can respiratory therapists work? I'll touch on a few. We work in diagnostic labs that may or may not be affiliated with a hospital. Respiratory therapists work in sleep medicine, which may be different than what the respiratory therapist does in a hospital setting. I'll say this, there are respiratory therapists who work in telemedicine. What's telemedicine? Online interaction between a patient and their caregiver, or in this case, a respiratory therapist. Now, I will say that's not a plentiful thing, but it is something that is growing, telemedicine. So that's an opportunity for some folks to work in telemedicine. There's pulmonary rehab, cardiac rehab, those sorts of things, physician's offices, etc. And I'll get into more specifics later with chapter 2. But different areas where respiratory therapists can work. However, the majority of respiratory therapists do work in a hospital setting. Do hospitals ever close? No. So the respiratory therapist could be in that hospital at any point during the day, at any point during the calendar, during the year. Does the hospital shut down on weekends? Of course not. So respiratory therapists are there 24/7, around the clock. Day shift, night shift, weekends, evenings, etc. Again, most therapists do work in a hospital or an acute care setting. Now, respiratory therapy really got its start in North America, particularly the United States and Canada, where we started as a profession. Now, respiratory therapists, or respiratory therapy, the field, has spread into many other countries. Some we'll talk about a little bit later in this lecture, but the term globalization of respiratory care. We are the specialized providers to provide respiratory care services. Our area of expertise is very specific. We have a very unique niche as far as what we know, what we do to assist our patients. Now going back, and I'm not going to get all big into distant history, but we do know that in early life, there was some sort of inhalation respiratory, some people may call it aromatherapy, where respiratory therapy was used therapeutically to treat whatever diseases or illnesses were thought of at that time. So the concept of providing respiratory care, respiratory therapy, does go back centuries. Hippocrates, who's considered the father of modern Western medicine. There's some things with Hippocrates, and some of this is a little trivial, but they didn't know back then what we know now when it's related to medicine. Hippocratic medicine was based on 4 essential fluids: phlegm, we tend to know phlegm, mucus, blood, yellow bile, and black bile. There was 4 essential elements: the earth, fire, water, and air, and all that dealt with hot and cold, and moist things. And anyways, back then, diseases were thought that there must have been an imbalance of this stuff, and that's why this individual was sick with whatever ailment they had at that time. Now, Hippocrates, again, we're talking 10,000 BC. Hippocrates, or actually 4th, 5th century BC, but he believed air, the air that we breathe, must have contained some sort of essential element or substance that was distributed to the body through the heart, via the heart. Now today we know, that special thing in the air that we breathe in is what? Oxygen. Again, they didn't know what that was, but they thought there was something, must have been something in the air that we would breathe in, and that our heart would pump that blood, carrying that special substance. Again, we know oxygen is what it was. Hippocrates, it's the Hippocratic oath that all physicians commit to when they're practicing. We don't have necessarily as respiratory therapists the Hippocratic oath like physicians do, but we do kind of follow that, the do no harm type principle. Aristotle, biologist who thought that a lot of information could be gained strictly through observation. Now, when you start to read some of the history of what early medicine was like and seeing how things worked, yeah, they did experiments on individuals and on animals to see, let's open them up and let's see how things work. Again, a little archaic by today's thought process, but that's how they had to learn how systems and how things operated. And if you gave them this, what would happen? If you took something away, what would happen? Now let's talk about a few folks. Now you will notice that Joseph Black, Joseph Priestley, I put them in bold. Okay, that's just a helpful wink, wink, hint, hint. Hey, you probably better know these guys, and you're going to find out there's several names through my lecture today. Again, as a subtle hint, yeah, I could ask a question about what's the big deal about that person? What are they known for, or why are they so important during John's lecture? So, Joseph Black, we're talking 18th century here, 1754. Joseph Black is credited with identifying carbon dioxide. Now, carbon dioxide we know is in the environment. We know when we inhale oxygen, our body uses that oxygen, puts off a waste product known as carbon dioxide, and we exhale it. Okay, so that's important for respiratory therapists. When we do arterial blood gas analysis, carbon dioxide is one of the major factors that we want to know about a patient, and knowing someone's carbon dioxide level tells us a lot about that patient's ability to adequately ventilate. But anyways, Joseph Black credited with the discovery, if you will, of carbon dioxide. Now, 1774, Joseph Priestley, he is credited with the discovery of oxygen. He did experiments. He found this special substance. Now, at the time, he did not call it oxygen. That was the gas itself wasn't named until decades later. He described it as dephlogisticated air. Dephlogisticated air. That's what he called this discovery of oxygen. And so Joseph Priestley credited with the discovery of oxygen. Now, just an aside here, and I didn't put this person's name on here for a reason, just to make a point. 1 year before Priestley's discovery of oxygen, there was another gentleman named Carl Steele. He actually discovered oxygen first. His experiment, he discovered oxygen first. But why isn't his name and his pretty picture on my screen here? It's because he never published nor documented his discovery. So what does that mean? Anybody that works in healthcare knows this. If you don't document it, what does that mean? It didn't happen. It was never done. So feel bad in history, this guy Carl Steele, no, yeah, and you can look him up, S-C-H-E-E-L-E, I believe is how you spell his last name. Yeah, he's the one who figured out that oxygen first, but he didn't publish it, he didn't document it. So Priestley, a year later, I don't think they knew each other, so I don't think Priestley stole his experiment. He discovered it independently from Steele, but he published his results. He is now credited with discovering oxygen. Another aside about Priestley. Anybody like a good carbonated beverage from time to time? Soft drink, soda? Yeah, I'm right here with you. He created the process of carbonation. I don't want to say he created soda, but the process of carbonation. Yes, thank you. Good job. Thank you. I appreciate that. Yeah, I do like a nice carbonated soft drink from time to time. All right, but that's Priestley. So I jokingly say this, the Joseph brothers, they're not brothers, they're not related, they just happen to share the first name. All right, so, but it's easy to get them confused. Oh yeah, it's Joseph, which one is it? And just so you guys know, and again, I probably dropped way too many hints early on in the program, but when I ask a question such as, who's credited with the discovery of carbon dioxide, Do you think I'm going to put Joseph Black? Obviously, that's the right answer. But do you think I'm going to throw Joseph Priestley as an potential answer option? Yeah. Absolutely, I am. And I'm going to put those Joseph names right next to each other to see if you start second guessing yourself. I thought it was this one, but it could be this one, and then you have to talk yourself out of the right answer, right? I don't do that to be mean. I don't do that to be cruel. MBRC does that stuff when you take the board exam. All right, so a few other guys here. Anton Lavoisier, he showed that oxygen was absorbed by the lungs and that carbon dioxide in water was exhaled. Now today we know that's routine, no big surprise there. But at that time it was. To realize the body does breathe in this oxygen, it's absorbed by the lungs into the body, and that someone actually exhales carbon dioxide. Next gentleman here, 1798, Thomas Beddoes. Thomas Beddoes is known as the father of inhalation therapy. He was the first physician to therapeutically administer oxygen to a patient. Now, oxygen is one of the most prescribed medications. Oxygen is a medication, doesn't require a prescription. It's one of the most prescribed medications out there, oxygen. Now we just assume, oh, well, there's oxygen here in the room. Why do I need additional oxygen? Does anybody know how much oxygen percentage-wise is in this room right now? 21%. But I can give a patient with supplemental oxygen much higher concentrations of it. Anyways, Thomas Beddoes is the one who first one to administer oxygen therapy as a therapeutic gas. That we take for granted today. Yeah, we give oxygen to a lot of people for a lot of reasons, but he was the first one to do it. So using this for patients with heart disease, at the time tuberculosis was a huge thing, killed a lot of people, among others. All right, moving on, we'll eventually get to 2025, but early 19th, early 20th century, a few things here. So John Dalton, he is the one that discusses the laws of partial pressure. So we said in this room right now, there's 21% oxygen that we're breathing in. Okay, well what's the remaining 79%? Nitrogen is the most, that's 78 point something something. And there's a few other things. Anybody have a guess? Besides oxygen and nitrogen, those are the two biggies. A little bit of carbon dioxide, but I will say still very small. Argon, another one, still very, very small, but there's a few other things. Anyways, Dalton describes the laws of partial pressure, all these different gases in our atmosphere. Gay-Lussac, he described the relationship between gas temperature and pressure. Now these two guys, we will get into some discussions about them and their laws, which I will just kind of group them under the gas laws. You know, all the different gases. I apologize about that vibration noise. Trust me, I'm going home today and I'm still going to hear it. That's why sometimes I get these crazy tics. All right. René Laennec. This was a French physician who got tired of when he would listen to his patients' lung sounds. The only way he could physically listen to lung sounds is what would he have to do? He would have to put his ear up against his patient's chest and back. Okay, breathe deep, breathe deep. Well, he was a male. He felt a little bit uncomfortable about putting his ear on his female patient. So, and plus, at that time, body lice was a really big thing, and you wouldn't want to put your face on somebody that has potential. So he wanted to create something that could distance himself a little bit from the patient. And so he is credited with creating the first stethoscope. But that does not look like a stethoscope that we see today. That was the first one, made out of wood, tubular piece of equipment that he could listen to his patients and hear his patients' breath sounds. Now I'm sure the quality of sound wasn't like we see today with our fancy stethoscopes, but at the time it was a big deal. It was one of the first diagnostic tools that we had available to us. So René Laennec. Louis Pasteur. This is mid-1800s. His discussion was about germ theory and that diseases could be caused by germs. That was huge at that time because it wasn't understood that there were microorganism bugs or germs that could cause illness. So he was really one of the first ones to say, yeah, there is small microorganisms. Do you think hand washing was a big deal back then? I'm sure it wasn't. I'm sure it wasn't. Do you think they did surgery and put gloves on? I'm sure they didn't. They had whatever all over their hands and they probably just shook it off. Give me some sort of towel or a leaf or something, a piece of cloth, and we'll get this junk off my hands because it's kind of sticky and gooey. Yeah, infection control wasn't a big thing. Hand hygiene was not a big thing at that time. 1882, so about 20 years later. Yes, Jeremy?
Is pasteurization a take on last?
Yes, it's part of that. Robert Koch, 1882, he discovered the tuberculosis microorganism. Because before people would get tuberculosis, they would die from it. There was no treatment. They had no idea what caused it. They thought it was genetic because it would wipe out families. So they thought, oh, it must be a genetic thing that mom's passing to the kids or dad's passing to the kids or they're both passing to the kids. What do we know today about tuberculosis? It's highly contagious. If I have TB, I'm talking, I'm coughing, I'm projecting, I'm laughing. Those tuberculosis bacilli can float through the room. Now you inhale it, now you have TB. So no wonder families were dying, groups of families were dying, and why people thought, oh, it must be genetic. Not because it was so highly contagious and so easily passed from person to person. Willem Roentgen, he's the one who discovered the process of X-ray. So 1896, aside from the stethoscope, I say that was one of the first major diagnostic tools we ever had. X-ray was probably the second. I don't know what we would do today if we had patients that come into the hospital and that we couldn't get an X-ray on. Yeah, I can listen to breath sounds and try to imagine what I must be hearing. But X-ray, that is so routine. Person comes in with anything related to chest pain, shortness of breath, we'll get an X-ray among some other tests. That's one of the biggies. All right, so moving into the 20th century. So early 1900s on, major advances in medicine. Oxygen therapy really took off as a therapy. Mechanical or artificial ventilation, airway management, medicated aerosols, medicines that we could put in an aerosol format for a patient to inhale, different cardiopulmonary diagnostic areas. All those things were advancing. And so at that time, we needed a healthcare specialist that could be trained in these things. So what do you think the specialist turned in to be? Us, respiratory therapists. So when did respiratory therapists, the field, the profession, really begin? Anybody have a guess? It's okay. 1940s. 1940s. Okay, so as a profession, we're not even 100 years old. Okay, 1940s is when we first started. Now we've evolved a lot since the 1940s as far as our names, what we're called. But at that time, these specialized practitioners, I'll use that word, because they weren't called respiratory therapists at the time. What they needed them for is to haul oxygen from floor to floor, from room to room. Unlike the hospital of today where the oxygen is piped in the walls, you can't see it, but I know there's an outlet right here and the oxygen's gonna come out of that outlet. They didn't have that back then. How did they carry and transport oxygen? In tanks. Big, heavy tanks. So when our field first started, who do you think, males or females, was probably the majority of those workers? Males, because of the heavy tanks. They needed somebody with some muscle that could carry these things. Up flights of stairs, room to room. these things, even the big tanks, don't last forever. At some point, they're going to have to be switched out. So, okay, back and forth again. In the beginning, we really didn't do assessment. We didn't listen to breath sounds. We didn't check pulse rates or heart rates. We were the oxygen people, the oxygen guys. They called us oxygen orderlies or oxygen technicians at the time, because that was our main role. All right, that was our main role. Sorry about the noise. It's my stomach. Oh, sorry. So, as far as training, there was a physician in Chicago, Dr. Edward Levine. He established the first OJT. What does OJT stand for? On the job training. On the job training. So OJT started in his hospital, not at a college or a school, in his hospital. Let's train these people and train them the way we want them to do things in our facility, in our hospital. So and to do more than just provide oxygen. Do things to provide more than just oxygen. So they've turned us from oxygen orderlies or oxygen technicians into inhalation therapists. And so our field was called inhalation therapy, not respiratory therapy, inhalation therapy. Again, folks were trained in-house, in hospitals, and that concept did start to spread around the country, going, oh yeah, we could train these people to do some other things related to what we currently do today. But there was no commonality between all of them. There was no structure. So if inhalation therapists that worked in Dr. Blind's hospital went to another place, maybe they do things differently over there. Or there's some things they do here that they don't do over there, or vice versa. So there needed to be some better training, a little more structured type training. Now let's fast forward again into the decades. Still, we're known as inhalation therapists. We're providing more than just oxygen therapy. We're providing positive pressure breathing devices that can be applied to patients. Today, if you were to say, John, what's a positive pressure breathing device that we provide our patients? I would tell you it's a mechanical ventilator. Mechanical ventilator, they all work through positive pressure, forcing that breath into a patient's lungs to expand the lungs. 1960s is when we got a little bit better with more formal education. Still, there were hospital-based programs. Some started to move into the college system or trade school type system for more consistent training to get these folks trained. 1960s, and you're gonna laugh when you think that's sophisticated. 1960s, the mechanical ventilators were advancing in technology. If you look at a 60s era ventilator today, you're gonna be like, that's an old-timey washing machine. That doesn't look right. But at the time, it was advanced. That was a huge advancement. And again, they needed somebody to manage it. The physician can't do it. The nurse can't do it. That's why they have the specialized inhalation therapist that can manage that ventilator. Our roles were also spreading into arterial blood gas analysis, pulmonary function laboratories. Again, for these lung people, us, that could kind of branch out. We're still working on the cardiopulmonary system, but our roles were beginning to expand. So 1960s, bless you. 1969 was the first Fundamentals of Inhalation Therapy textbook, now known as Egan's Fundamentals of Respiratory Care, the textbook we're using for this class. And again, I told you guys you don't have to necessarily physically bring your book to the class. I'm never going to call and say, oh, turn to page such and such. But if you were to look, anybody notice how many pages your Egan textbook is?
Over 1,000.
Well over 1,000. It was over 1,400 pages. The first, I think that's still a pretty good amount at the time. But if you were to look, and I actually have a copy of the first edition. I have the first edition, the second edition, and I think the 5th or 6th edition and every one thereafter. It's one of the things that I cannot get rid of, my Egan textbooks. Even though the old ones, I don't need them anymore, but they're on the bookshelf in my office at home, all kind of lined up there. And again, I'm missing some, I think the 3rd or 4th, I think I'm missing. But it's interesting. I don't know what your textbook cost, but I'm sure it was probably 3 figures, right? This textbook was $12. First Egan textbook was $12. You may ask, John, how do you know that? I'm not that old, I wasn't around then, so I have no clue. When I found the first edition Egan textbook, I'm like, oh my gosh, cool, this is respiratory history. I'm keeping this one. As I flipped the pages, there was a receipt still left in the middle of it. And that receipt was $12. And I'm sure in 1969, $12 was a lot of money. Makes me always wonder in today's world, when your textbook cost over $100, 55 years later, what's the book gonna cost then? You know, I'm sure there's gonna be no more paper, it'll all be digital, but what's gonna cost in the future?
Just because I'm curious, did you keep the receipt?
Yep, it's still in that same spot in the book. But again, the author was Dr. Egan. Dr. Egan since passed, but in honor of him, they're always going to name the textbooks from here on out after him. So that's why Egan's Fundamentals of Respiratory Therapy. Again, at the time we were inhalation therapists, so it's always inhalation therapy. All right, 1974. It's a date that's in bold. Take for what it's worth. 1974. They changed the name of inhalation therapist to respiratory therapist, where we've been named the same ever since. So 1974, the designation of respiratory therapist becomes standard. Again, the practice of respiratory therapy, originally in the US and Canada, North America, now expands globally. November of 1982, then President Ronald Reagan declared the 3rd week of October of every year as Respiratory Care Week. Now this occurred shortly after there was an assassination attempt on President Reagan. And his time in the hospital, he got to meet with some respiratory therapists, got to understand what our profession was all about. And so he declared, and we've been celebrating it every year since. Again, it's the last full week of October of every year. So generally you're talking 3rd week of October as Respiratory Care Week. All right, so talking about a few devices. Now, just to ease your apprehension, these things, I'm not going to ask you to remember their name, let alone year. I didn't put anything here in bold, but just kind of hear me out as we go through. So, oxygen therapy, 1907, first large-scale production of oxygen was created. Don't worry about this gentleman's name. Notice it's not in bold, so don't worry about that. 1910, oxygen tents were first used. 1918, oxygen masks first used. This is one of the first oxygen masks, known as the BLB mask. Now, don't ask me what BLB stands for, but it's the name of the 3 physicians, the last name of the 3 physicians, first initial of the last name of the 3 physicians who created this mask. They are originally from the Mayo Clinic, Minnesota, Rochester, that came up with this mask. Now, this mask was first used by pilots during World War II. You go up high enough, the air becomes thinner, amount of oxygen becomes less. So these masks could provide not just 21% oxygen like what's in the room right now, but it could provide anywhere from 80 to 100% oxygen. You know, when you're in a commercial flight, heaven forbid the oxygen masks ever fall because the airplane lost cabin pressure, those masks are providing higher concentrations of oxygen. So they adapted this from pilots' use during World War II into, hey, we can put this on our patients and provide our patients higher concentrations of oxygen. But the 1940s, notice the timing here, when did we start as a profession? 1940s. 1940s, oxygen therapy has become widely used. And again, partly because of our health, they needed people to administer and deliver that oxygen. Oh, how would you like to be the patient in this thing? This is an oxygen tent. to say, here, we're just gonna put this thing over your head. It's gonna be an oxygen-enriched environment, higher concentrations of oxygen than what's in the room right now, and you can breathe that in. I'm not a claustrophobic person, but I think I may have a little bit of an issue with this. Another issue, is there a lot of air circulating through here?
No.
No. So complaints were it would get hot inside those things. I get this thing off me. I'd rather live with lower oxygen concentrations in my body than have to suffer this way. But again, this was early usage. How about these? Sorry, they're a little bit low here, but these oxygen devices. This is a 1920s oxygen nasal catheter. Not a nasogastric catheter that some folks that work in a hospital have seen before. No, this is actually an oxygen catheter that gets placed into the nair and kind of sits and rests in the back of the nair. The other end is going to be connected to our oxygen, providing low flow supplemental oxygen to the patient. Same era, 1920s, this was a metal nasal cannula. The prongs that go into the nose, and now we just have a kind of a pliable plastic that can do that. This was metal. Do you think this stuff was disposable? We have so many things that are disposable, one-time patient use, and we dispose of them. We didn't have disposable stuff back then. When this guy's done with it, guess what we're gonna do? Let's go clean it, and who's gonna, okay, here's our next patient that's gonna have it. Yeah, I'm with you, gross, disgusting.
You can have your patients.
Yeah, right. 1970s, portable liquid oxygen systems for use in the patient's home, long-term oxygen therapy. We have patients today that live 24/7. They don't have to be in a hospital. They can stay in the comfort of their own home and receive oxygen therapy. We have concentrators that can get plugged into electricity, and that concentrator makes its own oxygen. Supplemental oxygen higher than just what's in the room right now, higher than 21% for patients that need it. Everything else is fine about that patient. They just need a little bit more oxygen than, say, you and I do right now. So that really expands the use of oxygen therapy and into home oxygen therapy. That's another thing. There's another avenue that respiratory therapists can work. Home care. That's another area where respiratory therapists, where you're no longer tied to the hospital, you're out traveling all around town providing care to patients that need it. And again, we'll talk more about the different areas respiratory therapists can work. Aerosolized medications. So that's a big thing. We have different aerosol devices, and you guys will learn all those different aerosol devices. We'll talk about them in this class later this semester. There's all kinds of different devices that can create and put that medication into a mist or aerosol form for the patient to inhale. Now these are some of the early aerosol devices. This was a glass bulb atomizer is what they would call them at the time, where liquid medication would be placed in. You'd squeeze that bulb and kind of create a mist. I always think about my grandmother. She used to have this glass atomizer on her dresser. I remember as a kid seeing it. And I mean, I wouldn't want to spray perfume, but I thought it was cool. When I pointed away and I'd squeeze that bulb, this mist would come out, but it was, for her, it was perfume. And she would get mad at me because I'm sure it was expensive. John, quit wasting my perfume. But they could put medicine in something similar and spray it for the patient to inhale. Again, changes that liquid from a liquid form into a mist or aerosol form for the patient to inhale. These are pictures of the first MDIs, metered dose inhalers, extremely popular today, a metered dose inhaler, where a patient can carry that with them. An asthmatic patient can take it wherever they want, and when they need it, they have it with them. Small, portable, simple, easy to use. Don't worry about the names here. I kind of just left them because the slide looked a little too empty without them. I'm not going to ask you any of these names. Don't worry. We'll get to the names when we get to that point. That's time to talk about drug names. In 1980s, there's advances in bronchodilator therapy. A bronchodilator helps to open up the bronchi, open up the airways. So I'll use the asthmatic patient as an example. Patient goes into an asthma attack. Their airways, instead of staying nice and open like this, they swell and constrict. So they need a bronchodilator to kind of help open and relax the smooth muscle. That's what a bronchodilator is. That's one of the primary aerosolized medications respiratory therapists do administer to patients. And how do we administer it? There's all kinds of forms. And there's more forms than just what I've pictured here. I just gave you kind of a smattering. Small volume nebulizer, dry powder inhalers. So instead of a liquid mist, it's actually a powder that the patient inhales. And we'll talk about all the specifics and things like that. This is a very basic, simplistic, elementary style small volume nebulizer that we still use today, but there have been so many advances in this type of technology to make it more effective for our patients. And we'll get into all that stuff later. Now, mechanical ventilation. Mechanical ventilation, or the concept of ventilation, artificial ventilation, has been around a long, long time, even longer than this. But a few things, if we want to compare it to today's modern mechanical ventilation. One of the first true artificial ventilators was the iron lung. And you may have heard of the word iron lung. You may have seen, in books or TV shows or history shows, I should say, patients living in an iron lung. There's been various styles, if you will, of an iron lung. They've evolved in their appearance, I should say, and how the basic function is all the same. So you may Google iron lung and see somebody's version of the iron lung, and you may look somewhere else and see a slightly different version, but they're all called iron lungs. So it evolved at the time. Now the first one, Drinker's iron lung, looks very similar to the next one, except this one was much more expensive. So this one became obsolete pretty quickly because this guy created one. I don't know anything about patents and things back then, so who knows. This one was, I don't want to say smaller, but it was a little less expensive. So that ended up being the one that took off. Now at the time, 1930s, 40s, 50s, the polio epidemic. We think COVID, we lived through COVID and that epidemic. There's been epidemics, obviously a lot before us, and there'll be some even after us. But the polio epidemic was huge. Infection could cause potential total paralysis. And when someone's respiratory muscles are paralyzed, guess what they can't do? They can't breathe. And so they need some sort of artificial ventilation. So the iron lung at that time especially was huge. They needed something to be able to artificially ventilate these patients who couldn't breathe adequately on their own. There were some negative pressure wrap ventilators that would wrap around the chest. The concept was the same as the iron lung. It creates negative pressure around the chest. Okay? In today's science of mechanical ventilation, we provide positive pressure to the airway, and that forces the air or the gas into the lung. In these examples, we didn't provide positive pressure, we provided negative pressure around the outside of the chest. We dropped the pressure on the outside of the chest, and that would force air into the patient's lung. That's how that science, that's how that technology worked at the time. Here's a picture of several iron lungs. These were Emerson's iron lungs, if I'm not mistaken. Now, a lot of things come out post-wars and post-epidemics. So one of the things that came out post-World War II, and you can say the polio epidemic that was occurring in the 30s, 40s, 50s, one was respiratory therapy, right? But also that came out of that was this type of ventilation, the iron lung. Another thing that came out of this, here's our real first example of an ICU. Now back in the day, there wasn't ICU this or CCU that. There was a hospital, everybody's there. They kind of created a centralized area to put these individuals in because their care was all going to be very similar, right? So the iron lung, the patient's actually inside the cylindrical tube. I'll give you some better pictures later in other classes and other discussions, but the patient's head would stick out. That'd be the only thing sticking out was their head. Again, think about what I said about negative pressure. negative pressure would be applied around the chest, and that would force atmospheric room air into their lungs. Okay, so if you said, well, how do they get more oxygen? Well, we'd have to put a mask or something on them if we wanted to increase that. But again, it was the negative pressure around their chest that would force air into their lungs.
Quick question.
Yes.
Would they still be able to eat, or would they have like a tube?
No, there was no tube feedings then. They could still eat. But again, they could still eat, they could still talk, they could still communicate. Now, they are lying flat, so there is going to be a lot of muscle atrophy over time. These little portholes here, in case anybody cares, well, how do you use the bathroom? These little portholes here, they would pass them urinals or things to go into. Now, depending on how severe the patient's polio was, they may be able to leave the iron lung for a certain period of time. But again, when they're leaving the iron lung, hey, you got to breathe on your own, buddy. There's nothing that's helping you. And so some patients could spend some time, even hours, outside of the iron lung, but as the weakness would continue throughout the day, they would have to go back in here and have to be placed back into their iron lung.
So that's curious that because I saw something last year where the very last person of living in or had one died last year.
It's scary to think about that. Even in the 2000s, there were people still living inside these.
Yeah, he passed away at 2024.
Yeah. Sorry. People that survived the polio epidemic on this, they may have gotten through, but their health was never the same.
He was
They
paralyzed.
would have to live inside this the rest of their life. So talk about just timing. So there's people that were in their 70s, 80s, 90s, that they've spent their entire adult life, because they contracted polio when they were a teen, late teen, early 20-year-old, lived in this their entire life. Now, obviously, technology advanced post this, and hey, patient, well, we could try this now. They lived in this for 10 years, 15 years. They didn't want to change. I don't blame them. They didn't want to do anything new. I'm not saying it's my opinion. In their opinion, I'm okay. I do what I got to do to survive. And so now you're talking decades. Now, let's just say around the 2000s, more of these individuals were beginning to die. The companies that made these things, didn't replace them, didn't create parts. So as these things would break, the patient had no other option but to go to more traditional current technology when it comes to
I'm saying that I'm literally where do you find someone to service that thing?
Yeah, you would. Yeah, today you would.
So people would sometimes be in these 24/7.
24/7. Yep, 24/7. 24/7. Yeah. When you get home, you can go to YouTube, type in iron lung, and you'll come across the stories of people that even in times you were alive, were still in their home living in these things. Now, you will hear, and again, it did require electricity. What happens, I know what happens here, sometimes a little bit of a storm, and boom, we lose power. If that's the case, this isn't operating. Now, I would say, and again, I can't say every single person, somebody's going to need assistance. If I live in this 24/7, I'm going to need some caregiver help, whether it's a professional or friends or family or whatever. This could also be operated manually. There was a pump, and you're basically pumping this, creating negative pressure, releasing negative pressure, creating negative pressure, releasing. So manually, it could be run, but if we're out of power, we better get a generator or something, because I can only do this for so long before I become exhausted and can't keep up.
You need one as well.
I think that guy that was talking about, I saw an interview.
Mhm.
He did a bunch of interviews, and he was talking about parts problem, that it's hard to find.
Yep.
That he never left shit for school to die, and he had caregivers when there was a problem.
So I just
A lot of people were abusing him and stealing his money. And
I just
because there's
Googled
nothing
him to confirm, and anyway, he ended up going to school to become a lawyer. Lived in that thing for 70 years, and he
70.
died
Yeah.
from contracting COVID.
Survived that epidemic and the next epidemic. Got it.
Wrote a book too.
Yeah.
I don't know what the book was.
Yeah, it's amazing. I can talk all day about the iron lung. Actually, when I used to do clinical rotations with students. I used to be the clinical instructor at some of our local hospitals. And in one of the local hospitals, I knew they had an iron lung. Not that they used for patients, but it was in storage. I knew where it was. And to get there, because I didn't want to bug security every time I wanted to show it off to a new group of students, but I knew if we went down a certain hall, if a certain door was open, I would peek in there and go, come with me. And it was really like we're breaking the law. We weren't, but I knew how to get to it. And I mean, you would sit there and do this, and yeah, it's covered in dust and it's gathering dust, but again, it's a piece of history of modern medicine, let alone respiratory care. And so I used to be able to take some students. Now, things changed. That hospital ended up kind of creating an archive, if you want to say museum, because it wasn't open to the public, but an archive area. And the respiratory director reached out to me. Now we're talking many years later. And he knew how much I loved to show that off. Now, just so you guys know, these things are massive. They're huge. From that wall to me, they're about this tall, and they weigh over 700 pounds. Anyways, the respiratory director of that hospital reached out to me and said, John, they're getting rid of it. They're throwing it out in the trash, basically. And that's what he said, do you want it? And I said, I do want it, but I don't know how it's going to get here. Give me some time to do a little research and figure out, well, the college has a big, massive van, and yeah, we could use it here, but the problem, how big is that elevator? It would not fit to the elevator. And to be fair, we really didn't have a place to put it or to store it. So I had to respectfully decline, and that thing is now gone. And there's one at the Smithsonian. I'm sure there's a few here or there places. And again, people that don't understand the history will think it's just an old piece of junk, get rid of it. And I mean, I get it. They're huge. You don't have a place to really store them. At the time, our lab here at North Campus was on the second floor. The doorway was very narrow, would have never fit through the doorway, even if we were able to get it to the second floor. And so our lab's bigger. We have a bigger door now, but it would
Now you're on the
not
third
the
floor.
space. But I was trying to convince our dean here at the time, hey, we need a museum of, and that sounds good. Well, I'm still waiting. That was 15, 18 years ago. Anyways, it's neat. If you ever get the opportunity to see one, just understand that is history right there, and you probably never see one again. I had a student that got to be kind of a dork like me and kind of really into it. When I was showing them that day, she was like, can I get in it? I'm like, I want to get in it too. But I said, okay, it's kind of had a helper in there. We didn't turn it on or anything like that. And I think the piece that kind of goes, we didn't close her in either, because what if that thing locked or got rid of it? All right, we're leaving now, everybody. But the piece that kind of went around the neck kind of dry rotted because it has to be somewhat snug. So, but she got in it, she's like, take my picture. I'm like, okay. Like I said, I got really jealous because I wanted a picture of me inside that thing and never got the opportunity to. All right, a few other things. This is the chest wrap that would create negative pressure. So that's probably, at the time, a good idea. I don't have to be in that box. And if you can create negative pressure around my chest, there is technology today that we still use this technology for other purposes. But it's going to look similar to that. Here's kind of a takeoff of the iron lung, but notice it's kind of propped up. And again, I guess if I had a pick, and I was going to be stuck in the iron lung, I'd rather be kind of sitting upright a little bit. I don't know if this thing could recline so I can sleep comfortably. But the other iron lung, if the person's lying flat, and this is not the best picture, this piece is a mirror. So if you're laying here and your head's looking up, you can see the mirror and you can see everybody around you. So I guess if you're talking to somebody, you're kind of seeing the world upside down. But that ventilation. Yeah, yeah. You know, you can't really turn, you know, at least in the iron lung, you can't really turn. Again, you could provide nursing care by opening those ports and kind of maybe some pillows or things to adjust, but yeah. But still, people live 70, 80 years in these things, and, you know, I would have thought, just like you, it's going to take a few years before I get a nasty decubitus ulcer and probably die from the infection. But obviously, they were able to manage. and get through it. All right, so that concept of the iron lung was all negative pressure. Again, negative pressure around the outside of the chest, which will force air into the lung. Now, positive pressure ventilation, what we use today, when it comes to mechanical ventilation, what we use today is positive pressure. Originally, that was used in the operating room for someone on anesthesia. Wasn't in the ICU yet. When we're talking here, now moving into 40s, 50s, etc., now they're starting to develop positive pressure ventilators. Now, for a positive pressure ventilator to work, there needs to be a breathing tube into someone's airway, or a tracheostomy tube into someone's airway, and then that piece of equipment through a circuit is connected. Has to be a closed system, because if it's not a closed system, you provide that positive pressure to the airway, it typically would just turn around and leak back out, trying to find a path of least resistance. So the system needs to be closed, forcing that positive pressure into the patient's lungs to inflate the patient's lungs, provide the patient a breath. Don't worry about names or years here, just kind of give you a little update here. So some of the early positive pressure ventilators were discussed here. I will point out this one, notice the year, we still use this, not necessarily for artificial ventilation, but as an assistance to help patients take deeper breaths. It is a technology that is kind of falling out of favor, I will say that, and it's hard for me because I learned on that thing, even though it's very, very old, but it's still, and you guys will get the opportunity to kind of practice and see what it feels like, or see how it operates, because we still use that more therapeutic. Again, not so much to keep this patient alive who can't breathe adequately on their own. And careful with the terminology here. At the time, 1960s, sophisticated styles of ventilators were introduced, such as this one, sophisticated. Again, at the time, this was cutting edge. We look at this and go, what the hell is that? And what are all those knobs and switches? Good night. Look at all these knobs and switches. They all did different things, right? They all did different things related to the patient's breathing. This, as the patient exhales, and you may see this in the movies or TV shows, and it cracks me up. That thing is so old, you don't see that anymore. When the patient would exhale, this bellows would rise and fall. And you'll see that in the movies, I guess because it looks cool on TV. We don't use this anymore. I have one of these in my office. I have my own little kind of museum in my office of stuff that I just can't throw away. Hey, that's a piece of history. But that was one of the early sophisticated ventilators. Yes, ma'am.
I've been watching ER, that shows from the 90s, and they have those all over the place.
So even though this was a 60s era, didn't mean that this was 1960, it didn't mean in 1969 they went away. Oh, no. These things, the older items, I should say, lasted a long time. If you ask your parents or grandparents, hey, when you needed, back in the day, when you needed an appliance, where did you go get an appliance? Because there was no Home Depot or Lowe's back then. There was no Amazon. Where would they go? They would go to Sears. They'd get a Kenmore, washing machine or refrigerator. And how long would that thing last?
Electrolux.
30 or 40 years. It would last forever. Kind of the same concept here. Things were built to last. And so, yeah, even though that ER TV show was in the 90s, yeah, you say, oh, that was 30 years ago. Yeah, they're still using it.
In the early days of COVID, when there was a ventilator shortage, a lot of hospitals still had some in storage and were using them as backups.
I'll tell you a story, speaking of COVID. When COVID shut us down, some of our local hospitals called me, reached out to me personally, goes, John, and this was early, push comes to shove, can I use your ventilators? Can we use your ventilators? And I said, well, let me be honest, they're not my ventilators, they're FSCJ's ventilators. I'm gonna have to ask my boss, who's gonna have to ask his boss, who's gonna have to ask her boss. And so I did, and they said, okay, you can do that. And so I tried to cover myself going, let me be honest with you, we have the ventilators that you're gonna see in the hospital used. but I can't promise that that thing has been calibrated exactly. Because all I care about, does it work in the lab for you guys when we're practicing and testing? That's all I care about. I don't care that it's perfectly accurate, because I was never expecting that to be on a human being. And they said, okay, but please have your biomedical people check it out and make sure. And so, okay, well, just in case, and we're talking early in COVID, before we really knew about what we were running out of at the time. And so, maybe a week went by, and at the time, we were no longer on campus, everything was remote. And so, I got a call from my boss, who said the college president reached out to him and said, Governor DeSantis wants any ventilators we could spare. And I said, okay, but remember, we promised so-and-so that they could use our ventilator. He goes, yeah, but whatever you can provide. Okay, so I turn around and call my friends in the hospital going, just so you know, if you want that ventilator that I got approval that you can borrow, if you want it, you better come get it now before the state comes and shows up. He's like, okay, no problem, when can you meet me? And so I met them out here and got them the good ventilators. And part of my thought process, again, wanted to be helpful in the situation we were all in, but at least I knew where my ventilators were, right? I knew they were with you, and I knew you would take good care of them, right? And so when the state came, and they did come, when the state came, I live in Clay County. I'm about 45 to 50 minutes away from North Campus. And my boss called me, John, how quickly can you get to North Campus? I'm like, maybe 45, 50 minutes, depending on traffic. He goes, okay, because the National Guard's at North Campus right now. I'm like, okay, I'm on my way. And so I have two boys. I asked them, you want to come with me? My youngest said, okay, I'll come with you. Get excuse to get out of the house. So he came up here with me. Sure enough, there was a kind of enclosed flatbed truck out here in front. National Guard members with their weapons. I'm like, you need some ventilators, guys? Come on. I gave them the oldest ventilators we had. We have since disposed of some of those ventilators because they were that old. They weren't this old, but they were the next generation. They weren't the iPhone 1, it was the iPhone 3 I loaned out, right?
How many
Even
do
though we're
y'all-
up to 16?
How many do y'all have here? Because you're like,
I don't remember off the top of my head, 8 or 9, you know? Back with the National Guard, so I come up here, come on guys, and so wheeled him out. They opened the back of the truck. It is loaded with ventilators. Loaded with ventilators. And I'm like, where'd all those come from? They've been hitting every respiratory program through the state. On their way up here, as they were going back down, I'm like, where exactly is this going? They didn't know. That's somewhere in South Florida. Okay. I took pictures of the ventilators, the barcode, everything else, and I'm thinking, I may never see you again. It's been fun. It's been fun, ventilator. Is there anything I need to sign, any paperwork? Again, these guys? Nope. They're walking away with their guns. Okay. And again, in my mind, I'm like, I'm glad I didn't give you my good ones. My good ones were local in our hospitals here. They were local. The old ones, we could survive. Those get lost or destroyed. And in my mind, yep, I was never gonna see them again. They closed those doors. Fast forward, whatever it was, 5-6 months later, and I ended up finding out they were gonna be used at a field hospital somewhere in South Florida. So tent city type hospital. They were gonna be there. Whether they were used or not, I have no idea. They probably saw the truck and all the ventilators on there and go, oh, we'll use that one last if we have to. That was mine, yeah. It said FJC on it, if anybody knows what FJC is, when we were known as Florida Junior College originally. Still had an FJC sticker on it. And so, fine, it is what it is. 5-6 months later, get a call. Your ventilators, they're delivering your ventilators. And I'm like, but there was never paperwork. They never once said, FSCJ gave us these, let's tag those or whatever. I'm thinking, and I was telling my coworkers at the time, I said, when that truck backs up, they say, well, which one's yours? That brand new one right there? That's the one I gave you. I thought this could work out really well for me. No, somebody did paperwork somewhere because they knew that the ones I gave were the ones that we got back. Oh man, oh well. Nice to see you again, buddy. And it was, I think, a year later I ended up surplusing that one. Again, wish we had a museum and I could say, hey, we could display this one later. But anyways, yeah, that was an interesting time. But this, lots of knobs and switches. So I know we're not even anywhere near close discussing mechanical ventilation. But just so you guys understand, when I say, oh, turn the dial or turn or flip that, in my mind I'm picturing something like this. Now some of the new ones do still have a single dial that you can press on the screen, whatever you want, and then dial it to whatever. All right, advancing here. So moving out of the 60s into the 70s, advanced volume ventilators became available in the 1970s, such as the Servo 900, the Bear ventilators, the MA2, which was a takeoff of that one on the previous screen, which was the MA1. Only reason I give you these is because I came through this very program in the 1990s. Okay, so I am an alumni of this program. Came through in the 1990s. We learned on this ventilator. We learned on this, actually we learned on both of these ventilators as a matter of fact. That was modern, considered modern at that time. Even though, when did these things come out? In the 1970s. So just like the show ER that was still showing some of this stuff, hey, because they still worked. They were like the Kenmore washing machine or refrigerator. They lasted. So science and technology has evolved a lot more since this stuff. Again, notice all the knobs and switches, and this one was very complicated. If you turned this, you had to turn that. If you turned this, you would change 2 other settings not knowing you were doing that. So it was a very complicated ventilator to work with. First microprocessor controlled ventilator developed in the 1980s. Puritan 7200 in 1984 was one of the first actually computerized ventilators. 1988, the concept of non-invasive ventilation. Now what non-invasive ventilation is ventilating the patient, but not through a tracheostomy tube, not through a breathing tube, simply through a snug, tight-fitting mask on the face. If anybody knows what CPAP is, CPAP therapy, we'll talk about that a little bit later today. CPAP therapies, patients can use CPAP therapy in the home if they have sleep apnea, provides positive pressure to kind of keep the airway open. That was late 80s, early 90s, and I will call that a form of ventilation, was developed. But between 1970 and 2004, there was more than 50 new ventilators. Again, it's amazing if you can kind of follow the trend of how technology evolved over those 30, 40 years and how it continues to evolve. I will also say, where these things lasted decades, the ventilators of today, and even the ventilator companies tell me, yeah, we don't expect that thing to last more than 10 to 15 years. They're business people, they're smart. If it lasted 40 years, would we buy from them ever again? No. We would need them to fix things when they break, but no. So just like our washing machines and refrigerators, do those companies expect those things to last for 20, 30 years? No. 10 years, give or take, and yeah, it's gonna be too expensive to repair it, you're gonna buy a new one. And that keeps our company making money. So same thing with mechanical ventilation. These are just a couple of images of what a ventilator may look like today. To be honest, it looks like an iPhone or some sort of smartphone that you can still touch the screen to get to other screens, other areas. You can open, you can close. Still may have a dial or a knob, but that may be the only one that's on there. Nice colorful graphics and waveforms, which the older ventilators did not have. But that's something. This one's really cool because even during ventilation, you can see this lung expand and contract. Like, that is so cool. Shouldn't say this to you guys, but I get so cool, and I don't even look at the patient. I should look at the patient's lungs rise and fall, right? That should be the thing I'm actually doing. But this is really, really cool. It's in color and all kinds of different things. All right, just to give you an example, so ventilator, invasive, I know these pictures are not the clearest, invasive, so this gentleman has a breathing tube in place. We call that an endotracheal tube, a breathing tube in place, where this patient's on non-invasive ventilation. Notice the mask. And this is just not some loose, dangling mask. This mask is snug and tight-fitting. Again, these are positive pressure machines forcing pressure into the lung. If the mask on the non-invasive ventilation was loose, that pressure would go right out to the room and not go into the patient's lungs. So it's something you guys will learn in time on how to put those masks on. Has to be snug, but obviously you don't want to cut off blood supply to the skin because it can cause ulcerations and problems on a patient's face or nose, or the nose, depending on which mask you select. A few things here about airway management. That's a big part of what we do as a respiratory therapist. So airway management involves various use of techniques and devices to establish or maintain a functional airway, an airway that can remain open. First endotracheal tube was applied to a patient 1880. 1880 was that first concept of a endotracheal tube. 1913, the laryngoscope was introduced. The laryngoscope, which you guys will learn in time, is really kind of could be a plastic or metal type device that helps to open the airway so you can see structures. So you know when you place that endotracheal tube that you're placing the tube into the airway and not into the esophagus. Because again, we don't breathe in our stomach, we breathe in our lungs, so that tube has to be properly placed. 1941, first suction catheter was described. Again, suction catheter would go down and do what? Clean out that junk from the lung, clean out that mucus. Cardiopulmonary diagnostics. So we can measure a patient's breathing. We can measure the volume of air a patient can breathe in. We can instruct a patient to do different breathing techniques. Breathe in deep, exhale fully, blast the air out of your lungs, blast the air out of your chest, and we can measure all that stuff. That concept, that whole testing is known as pulmonary function testing, PFT for short. Respiratory therapists do work in pulmonary function labs. We have intimate knowledge and understanding of what the lung volumes and capacities are. That's something we'll be talking about a little bit later this semester, looking at lung volumes and capacities. Do you know when you fully, completely exhale, there is still air left in your lungs that you can never, ever exhale? There is still air left in there. They call that residual volume. And we'll discuss that when we get to that portion. I believe that's in the second class. Not today, but in the coming weeks. Blood gas analysis, sleep medicine, the term polysomnography is the sleep test that patients could have done to see at night. Are they not breathing well enough? Are they stopping breathing? The term apnea means cessation of breathing, that you're not breathing. So patients with sleep apnea will just simply stop breathing periodically throughout the night. And depending how severe they are, you can have a patient that stops breathing hundreds of times during the night. We'll talk about that a little bit more in the next class. But that was 1980s. Now let's move on to a few other items here, such as our professional organizations. Our professional organizations. Again, when did we start as a profession? What decade? 1940s. By 1947, the Inhalation Therapy Association was created, the first professional organization for inhalation therapists. You know what today we know as respiratory therapists. Now, everything on here is still the same organization. They've just changed their names over the years. So 47, again, the very first Inhalation Therapy Association. 1954, it name-wise changed to the American Association for Inhalation Therapists. Again, they're representing our field, our profession. That was changed 1973 to the American Association for Respiratory Therapy. Again, what year were we called respiratory therapists? 1974. 74, so this all coincides around the same time. 1982, name changed to what it's currently called today, the AARC, American Association for Respiratory Care. And that's what it is known as today. I think I may even talk about it. I don't remember what I put on the slide. Hey, I'll talk about it in just a second. All right, so the AERC has affiliations with every single state. So every single state has their own professional organization that is a chartered member of the AERC. AERC is the national organization, but each state has their own, again, with specific interest for that particular state. Going back to what the AERC does, they advocate for our profession to legislative and regulatory bodies, insurance companies, as well as the general public. Now, you might not think that doesn't sound very important, but remember, especially in today's political climate, that when somebody wants to change a policy or change something, God bless you, that they can do it, they can vote on it and do it. So, are there any politicians out there that are respiratory therapists? I don't know for a fact, but I would probably say no. They did this to do other things. So we need somebody that can go to those politicians and say, hey, don't forget about us. Don't forget about what we do.
They're basically lobbying.
To remind them, we have lobbyists. The AERC has lobbyists that lobby on our behalf when the lobbyist sees, hey, they're doing some changes here to maybe Medicare, Medicaid reimbursement, or different things, and neglecting to include respiratory therapists. And so they will notify the AERC. AERC notifies their membership, us. You know, they need letters, they need emails sent. You know, it's honestly, for our perspective, it's very easy. They just need our support. Now, for those that are interested and want to get more involved, yes, there's opportunities for respiratory therapists to get involved with the AERC and help them. A lot of times you'll see the AERC post pictures of a group of respiratory therapists that went to DC, spoke to this politician, this person about an upcoming bill, and making sure that respiratory therapy was included or different things. Anybody wonder, and again, some of you guys might be old enough to even remember, but back in the day, on an airplane, you could smoke. You could smoke on an airplane. I can't speak international travel, but I know in the United States, you can smoke on an airplane. If your airplane's old enough, you may even see those old ashtrays. It makes me nervous that this plane is so old that we used to be able to smoke on this plane. They don't change the seat out, and I still see that little ashtray there in the center. If you're curious what organization was instrumental in helping pass policy or influence, again, the AERC doesn't have the opportunity to pass policy, but to influence the politicians to vote, it was the AERC that helped to spearhead that, to not allow smoking on flights. So again, I can because I lived through it, but I still can't believe that there was a time. I tell my kids this story. My boys are in their 20s. When I tell my kids this story, they're like, "Ah, it just seems so weird." I'm like, it is weird now when you think about it, but at the time, that was our world. That was the normal, right? AERC also sponsors continuing professional educational activities. Even when you graduate, you're still going to be required to maintain a certain amount of education, right? Annually or biannually, a certain number, we call them CEUs, continuing education units, to make sure you stay current. It's a requirement in every single state and every single state may have a different number, but that you have to complete so many CEUs. In the state of Florida, it's 24, and you have to complete those 24 CEUs in a 2-year period, because our license is good for 2 years. And so you can go to their big conferences, you can attend their webinars, you can do some home study, self-study, that sort of thing to stay current. And it's, again, your responsibility to make sure you keep track of those CEUs that you've obtained. You keep your certificate or whatever that says, yeah, you sat through this hour lesson on blah, blah, blah. That's your responsibility when you get licensed. AERC provides publications, their sophisticated website. AERC.org is their website. You can peruse it, after class today just to see what is there. There's lots of good stuff there. There's even areas set for students. They even have a student membership, which is not too expensive, I don't believe. If you sign up, and again, you can sign up as a student while you're a student in the program. And you can see they've tiered this. So First year, annual membership is $25. Second year, when you renew it, $25. Now at that point, you would be graduated and working as a respiratory therapist, so they bump up the fee a little bit to $40. Year 4 at $60, and by year 5, you're paying regular price, which I pay about $100, give or take, annually for my membership in the AARC. So they help kind of financially ease you into their process, but you can only do it as a student. And I always remind our students, especially those students that are getting ready to graduate, don't wait, because the second you graduate, what are you going to pay if you want to be a member of the AARC? Whatever this rate is. So you don't get to kind of financially ease into it. You can see for the 25-year, you'll get access to possible mentors, exam prep materials, and that exam prep materials could include things related to class, or more importantly, things related to the board exams. Scholarships. Want to make your $25 stretch a lot further, scholarships. There's one other thing I was going to mention here. It's on the website. I couldn't put everything that's on the website on the screen. I just want to hit some of the highlights. Oh, I remember what it was. When you take your board exam, when you sign up for the board exam. Now, I don't know how it's going to be with the new test, so forgive me here if it's slightly different than what I'm about to say. But for our class that just graduated, if they're an AARC member, they can save $40 on their second test. Remember, right now there's 2 tests they have to take, so they don't get a discount on the first test, but the second test, the clinical simulation, they can save $40 on the cost of that test. Now, I don't know how it's going to be when you guys graduate, because it's going to be 1 test. I would assume, hey, you better give me a discount on that 1 test, because you did it before with the 2 tests. But so you may say, well, I am getting my $40 for something. It's just not going away, but I am can save some money by being a member of the AARC. There'll be times in the program where we have some of our own local members that would like to come and talk to you guys and talk to students, and I always welcome them to come out whenever they want to talk about the AARC, or even our own state affiliate of the AARC, and that's the FSRC, the Florida Society for Respiratory Care. That's their website. So everything that AARC does for us on a national level, FSRC does it on a state level. So instead of the FSRC being in particular legislating or advocating on our behalf in Washington, D.C., where do they go? Tallahassee. And advocate for us there in Tallahassee for things specific to the state. Any laws or any things that the state is changing or things that are passing that, again, influence the respiratory therapy profession, our advocates and lobbyists are there. State licensure. State licensure. So when you graduate and pass your board exams, you will be applying for a state license. Now, state licensure for respiratory therapists started in the 1980s. Actually, just trivia here, but in 1982, California was the first state to have require a license in respiratory therapy to practice. I don't remember exactly when Florida's was, but it was sometime later. But California was the first in 1982. Every state, with the exception of Alaska, every state requires licensure, requires an individual to get licensed to practice respiratory therapy. Without licensure, anybody can do the job. Not that they know what they're doing, but without a license. So, like for example, somebody that cuts hair, do they have a license to practice in the state? Absolutely. But could I cut somebody's hair? I sure could, I would love to, but I'm gonna do a horrible job at it, right? Because I'm not trained, I'm not licensed. They would never give me a license to cut hair. But that's the importance of licensure. Also with licensure, to get a license granted, you have to show that you're competent. How licensure works is, well, what determines if you're competent or not? Did you pass your board exam? That's what they require. Additionally, they will do background check on you, so wouldn't that be a good thing as a public member, perhaps receiving respiratory care, knowing this person taking care of you doesn't have things in their history or their past that could be subject to problems. So yes, so to get licensed, the state will do a background check and make sure there's nothing there that could potentially be a hazard or a harm to a patient. State licensing laws set minimum educational requirements. For example, AS degree, BS degree, master's degree, the state could set those forward. The state could also say you have to be at least a CRT or you have to be at least an RRT. Again, the state could determine that. And I know I probably will talk about that when we get to chapter 2, and I think I inferred it the other day. There's some states right now that you have to have the RRT credential to get a license in that state. Florida's not there yet, but we're getting there. The state licensing board also sets the requirement of continuing education. Like I said, the state of Florida requires the respiratory therapist to have 24 CEUs in a biennium in a 2-year period. In addition to of those 24, there are certain mandatory ones that you have to have. Medical errors is a mandatory one. Of those 24 hours, excuse me, 2 hours has to be in medical errors / patient safety. Another 2 hours has to be what they call licensing laws for the respiratory therapist. So of those 24, you can have those 24 in pretty much anything you want, but those 2 and 2, those 4 have to be very specific. Now, by the time you guys graduate, could the state say, oh, we want to make sure you have 1 hour in such and such? They could, as things change. When we went through all those, started with Hurricane Katrina, when we went through all those natural disasters for probably a 3-year biennium period, we had mandatory requirements on disaster preparedness. They've since taken that away. But could that be another one that comes back to the forefront? Absolutely it could. But don't be confused. This is the Florida Board for Respiratory Care. They are different than the FSRC. Comes back. Who is the FSRC? They're the chartered affiliate of the AERC, our professional organization. Florida Board for Respiratory Care, those are the people that issue you the what? License to practice as a respiratory therapist. Now, they don't have a nice fancy acronym of FBRC. They don't. That's the name, Florida Board for Respiratory Care. I'm guessing that acronym must have been taken by somebody else.
They're essentially under the Florida Health.
Yes.
Yeah.
The Florida
Department of Health. Yeah.
Yes. They're housed out of Tallahassee, where all the other governmental state agencies are. But when you get licensed, after you pass your board exam and you get licensed, you go through them to get the license. And you go through them every biennium when it's time to renew your license. The MBRC, so state licensure, to get a license in a state is based on the respiratory therapist passing the exam or examinations administered by the MBRC. So who's the MBRC? They're the people that test you after graduation, because minimum to take the test is you have to be a graduate of a respiratory care program. You graduate of the program, now you can take their test, not John's test, their test. And that's who's going to test you. Do they issue you a state license? No. That's the Florida Board or whatever state board of respiratory care. And if you think you may be moving out of state somewhere one day, you can always get a head start. Google that state's name, Board of Respiratory Care, and see what their requirements may be. I will of course always talk about the state of Florida, but who knows, some other state may have some additional requirements. I had a student that graduated this past May that moved to Illinois. There was paperwork that I had to complete on her behalf, that the college beyond me had to complete on her behalf so she can get licensed. And I laughed, and she laughed too, because she said, John, it's all on paper. I said, they don't have an electronic format of this? No, they're working on it. I'm like, and she's currently working in Chicago. In Chicago, that's where respiratory therapy started, at least the training anyways. They should be much more, and she goes, they're not. And everybody knows that, and because it's not electronic, it's not digital, the process takes a lot longer. So she came to me well before she graduated, you know, that last semester, but like with still more than half the semester to go. And I said, well, you and I, we need to get started on this so there's not this delay when you graduate waiting for your stuff to get processed. There's some things I can't say, like I can't say you're a graduate because you haven't finished the semester yet, but when we get there, and so she literally, last day of class, the next day she was flying to Chicago to go live. Meanwhile, the paperwork process was starting. And I happened to check with her, this was over the summer, check with her, make sure everything was going okay. I know we did our part. The rest was all on her. And she goes, yeah, I'm working now, and da-da-da-da. So all that was great.
We don't have an option for a multi-state license, like for nursing.
They are working on that. There's a thing going around right now called the Respiratory Compact. And they're trying. Right now, and I forget the number, don't quote me on this, I want to say to have a licensure compact, which means you fill out one group of paperwork and suddenly now you're licensed in multiple states. And it's not like they're all together, it could be all over the place. But I want to say they need 8 or 9 states to sign off on this compact. I believe they're there right now. Don't quote me on which states, I'd have to look that up, but I know Florida's not part of the compact yet. They're talking about they would like it, makes a lot of sense. Because what if you happen to be a traveling respiratory therapist? There's a lot of respiratory therapists that travel and make good money traveling, and you get to see other cities. You may be in another place for 6 months if that's the contract you sign, and then another 6 months you're someplace else, and then maybe you're someplace for a year. You know, if I was young and didn't have anything that kept me here, what sort of traveling opportunities are in Hawaii right now? I want to, cost of living is going to be extremely high, but I still want to see what respiratory therapists do in Hawaii, or California, Texas, wherever the place may be. But if you didn't have the compact, which like right now the state of Florida doesn't, you would have to have a state of Florida license and whatever cost that's involved, and Georgia, if that's, you want a license there, and Illinois, if that's where you want. So I mean, it could get expensive, and every state's different. Every state's different.
Alaska's beautiful and they don't require one.
You could probably guess which state's probably the most expensive to get a license in. California, and I want to say it's like over $300-400. I had a student from the last class that moved to California, and I said, you got to let me know how it is to get licensed over there. But yeah, I think she said it was going to cost her like $400 to get a license there. But one thing, and she knew this graduating, you have to have your RRT. If you don't pass the test, the RRT level, you can't get a license in the state of California because they're one of the ones that require the RRT. I'm sorry, I saw several other hands going up.
Is it locally, like the NVRC, like is it recognized globally or is it just?
It's hard for me to say globally because there's so many uniqueness. So for this is I'll talk to the United States. I don't know international what's required, and every place, every country could be slightly different. But in the United States, when you take and pass their test, you are now an RRT or CRT, if that's the level, nationally in the United States. Now, that means if I go to any state, they will recognize my passing of their test and grant me the license, as long as I meet the criteria, whether it's RRT or CRT or either one. As long as I meet that. So I don't have to go to another state and take another test. That'd be a pain in the butt, wouldn't it? Because every state you went to, you had to take another test. Help me here if anybody's EMT, paramedic, isn't that? Is that way in EMT or paramedic? There's a state test, and if you move someplace else, there's another test. Yeah, I know they're different than us.
It's similar, like there's a national registry, but some states they'll issue their own licenses.
Gotcha. But you would have to take a test.
Yeah,
in that
like
state.
if you're national, but you live in like, say, I don't know, Colorado, and you come to Florida, it doesn't really matter that you have your national, and you still have to pass the state test.
I got you. Okay. So that's what somebody told me. I think I may have screwed it up a little bit, but I knew that they would have to take another test. We would not. Okay, let me be clear. We would not. Right? Because that would make me nervous. I mean, I teach this stuff, and I would be nervous if I was forced to take another test, right? If 20 years went by, you were working in the state of Florida, great, and if you had to move someplace else and they said, oh, you gotta take a test, like, Doesn't mean I don't know respiratory therapy, but maybe I'm not sure of how they're testing nationally. When you take and pass this test, you will never have to take that test again. Unless you let your credential lapse. Again, I'll put the asterisk on that one. But you would never have to take that test again.
This is like completely different, but to kind of like answer your question a little bit, I know for like being a chiropractor, like if you wanted to move to England, they would give you a competency exam, and then you would be like licensed there.
Gotcha.
So it's a lot like that, like in different like countries and stuff like that. Like if you pass it here, then you could go and take like their competency exam and just make sure, okay, I'm gonna pass it.
And I'll be, every place is different. Every place is different. And if you reached out right now and find out, okay, this is what has to be done, who's to say it's not gonna change in 2 years?
Well, the reason why I was asking is because you know, like, we're like travel RTs,
Mhm.
I was like wondering how that works, is it just?
Yeah, because you have this credential and it counts nationally in the United States, you will still have to gain a license to practice in that state, but that doesn't mean you're taking any additional tests. You're filling out the paperwork and paying for that license, but there's no additional testing. You've done the hard, this is the hard part. The other is filling out paperwork, again, making sure there's nothing in your past that could affect your ability to get licensed in that state. But on the flip side, I've had students in the program that were respiratory therapists in other countries trying to come here and practice as a respiratory therapist, and they could not get licensed because they didn't take this test. And this organization would not allow them to test. Requirements to take this test is you have to graduate from an accredited respiratory care program with a minimum of an associate degree. That makes you eligible to take their test. A respiratory therapist that comes from another country doesn't have that. They don't have to follow the accreditation that we have to follow. And so I've had several of those individuals reach out to me, is there anything I can do? Well, you can talk to them and see, and NBRC always says no. Call one of your local respiratory programs and see if you can get in as a student. And once you get in as a student, okay, you've got to go through the same thing you guys are going through to graduate with the degree. Once you have the degree from the program, now you're eligible for their test. And that has happened several times over especially the last several years. Some of those folks, very, very sharp. You know, they had a respiratory therapy degree from their country. They still had to come here. There was no credit that I could give them. They had to start. And I will say, in some instances, people may say, well, that's kind of hard. You got to kind of start all over again. Yeah, but some of the things they learn, how they do in their country, is different how we do it here. And I've had several of those same individuals say, you know, to be honest, I hated having to start all over again, but I'm glad I did because I learned the way you guys do things in the US that we didn't do over there. And what about medications and drug names? Yeah, they are different. They are different. So that's a whole nother avenue. Okay,
I see that it says RRT, CRT, but what is the RPFT?
We'll talk about that. That image, that logo is a little bit dated.
Okay.
But RPFT stands for Registered Pulmonary Function Technologist. CPFT stands for Certified Pulmonary Function Technologist. I'll talk more about that come next week with chapter 2. But in addition to, and again, when I say examinations, more than just the 2 that we have talked about currently, the MBRC offers additional credentials, which means additional testing in areas that are unique. Like, for example, if anybody noticed on my name in the syllabus, it said John Salazar, MED, I have a master's in education. After that it said RRT, Registered Respiratory Therapist, and after that it said RRT-NPS, NPS, Neonatal Pediatric Specialist, because I took that credentialing exam and passed that, so I have that NPS credential. And there's others, and PFT is another one that you can have. And again, I'll say the same stupid joke next week that I'm going to tell you guys right now. When you go through, finish the program, take the test, and take all the potential tests that the MBRC offers, your name badge is going to be like that. You're going to have all these letters after your name, okay? In different specialty areas. You know, so if there's an area that really is of interest to you again, too early to think about it right now. Get your RRT first, that's number one. But after that, if you're like, yeah, I wanna work with kids and I wanna stand out and say, hey, I have the specialty credential indicating I have knowledge in that area, then go take the NPS
Do those
test.
require further education or just studying and then take the test?
No further education. Your degree is enough. Now, some of them do require you to have the RRT to take them. Some may just be CRT, but most of them do require the RRT to take them. But no, it's just a matter of passing another test. And when we get to it, somebody may say, well, will I be ready once I finish my RRT here to go and take that NPS or PFT or whatever? I'm gonna be honest and say, you probably need to review some additional things, because that test is gonna be very specific to that content area. Now, the RRT credential that you've earned, it's gonna talk about, that test is gonna cover all of those areas in a very superficial way. But when you take the specialty test in that area, those questions are gonna be very specific to that
More of a
area.
deep dive.
More deeper as far as knowledge and understanding goes. So we'll talk about that a little bit more next week. I'll show you all the different ones that you could potentially earn. But like I said, your name badge can look like this with all these letters after your name. And everybody says, what's all that mean? Well, you got 20 minutes because it's gonna take me a minute to explain it. And it was, I know several hands kept kind of going up and down. I'm sorry if I missed or overlooked. So mbRc.org, that's their website. You'll eventually be intimately knowledgeable and involved in the NBRC when it's time to take their tests. Respiratory care education, again, first formal program. Remember OJT, on-the-job training initially in the 1940s, 1950s, a little bit more structured education. Again, some of these trainings were still hospital-based, could have been college-based, could be trade school type based. 1960s, programs are multiplying. Most of them are at the time hospital-based. Right now, currently, and I need to double check the number, but I just simply took this from the Egan textbook that you guys have because it's the latest edition, 443 current respiratory therapy programs in the United States. Most of them are associate degree levels. Fairly, probably 70, 80 of those programs are probably baccalaureate level, if not trending a little bit more, and a handful of master level respiratory care programs. Again, the minimum requirement of the NBRC is that you have an associate degree. There is a strong push in the profession to let's keep advancing our education. I would love for FSCJ one day to offer a baccalaureate degree in respiratory care. We're not there yet, but it's not from lack of trying. Really pushing my administration hard. There's certain things that are easy and certain things that are not so easy when you make that sort of transition. The way the Florida education system is structured right now, and we're actually in a good place because as a quote-unquote community college, we can offer baccalaureate degrees, yes. Some states you can't, but here we can. But we have to be careful for funding purposes that we get from the state. There's some funding that we get because we're an associate degree program that leads directly to a workforce job that we get funding for. If we were to eliminate that and say, no, we're going straight baccalaureate, then there's going to be funding we're going to be missing out on and not being able to get. Which, when you wonder how we have so many fancy, sophisticated mechanical ventilators, and a ventilator today can cost anywhere from $30,000, $40,000, $50,000, $60,000 for one. Those things aren't cheap. My truck's not even near that cost. That's why when you're in the hospital and somebody says, hey, bring this ventilator over to this ICU, and you start pushing it, you better not drop that thing, because that is minimum $30,000, $40,000, $50,000, $60,000 ventilator. We couldn't afford those as a program, as a department, without some of that funding coming from the state. But in addition, there's also several accredited respiratory care programs in Canada, handful in Mexico, South America, Japan, India, Taiwan, Qatar, as well as other countries, and it's only continuing to spread because other countries are beginning to understand and appreciate the specialized nature of what we do. Again, people can be misinformed and think, well, can't the nurse do that? No, the nurse has a lot of other responsibilities and duties. They don't need this thing added to it, especially when it comes to mechanical ventilation and ICU care. They are happy when we're able to contribute and be there for their patients as well. Yes?
Is there any difference between people who graduated with associate's degrees and bachelor degrees and what folks like?
That's a good question. So, is there different things related to the job that someone with a bachelor's degree or master's degree can do that maybe an associate degree student can't? There could be some things there could be some positions that require you to have a bachelor's or a master's. For my job, if I didn't have at minimum my bachelor's, I would have never been able to work here. So there's some areas, there may be some areas for advancement that maybe one day, and again, I know it's early for you guys, but maybe one day, hey, I want to be a shift supervisor or departmental director. Well, maybe there's a minimum education requirement for those positions. One nice thing in respiratory care, there's several baccalaureate programs that are known as degree advancement. Degree advancement, meaning you graduate from our program, you have your RRT, you can join this baccalaureate online program and complete the requirements to get the baccalaureate degree. Carrying what you learned here with your credentials and being able to get that instead of having to start all over at the ground floor and work your way up again with a bachelor's degree. Again, it's called degree advancement. Those programs are geared specifically for the working respiratory therapist because they expect, okay, you've got your associate degree, you're working in the field, we'll make the schedule structured so much that you can attend class and still be able to work. And we could talk about those a little more specific on another day. I'll have to do my research to see what's out there right now. But there's several programs that are like that. I will also say when you're investigating that yourself personally, look at cost. I would say, dollars matter. You might find a great program in another state, but are they going to charge you out-of-state tuition? And you know what out-of-state tuition looks like? That's like 3 times the standard in-state tuition. But there's also programs that may charge you, and I don't want to say it because I'm going to be guessing, my memory could be off. I know there's at least one for a fact that charges in-state tuition even for an out-of-state student. So the cost isn't ridiculously high. But I also do know there's some, even in our own state, baccalaureate degree advancement programs at private schools that the cost is significantly high. So do your homework, do your research if that is something you're considering. I'll tell you my story. When I graduated from this very program, I knew if I didn't do it at that time, I probably wouldn't do it. If I waited, I'd probably get complacent and get comfortable doing what I was doing and never go. So the second I graduated from this program, I went on. Now we're talking 1990s, there was no such thing as online education, so I had to go to wherever that program was. The program's since been closed, and it's sad because I'm an alumnus of the University of Central Florida, UCF. They had a very good baccalaureate program for respiratory care where they took my RRT credential, gave me what they call credit by examination by passing that RRT test, which I would have done anyways whether I was going to UCF or not. They gave me 1 year's worth of credit, meaning when I took my bachelor's, I took it for 1 year. I had to go to school there for 1 year as opposed to the expected 2 years because they gave me credit by examination. And there's some programs that still have that credit by examination. I've even invited some of those schools to come talk to my current class, about those opportunities. I think we're too early to discuss that right now because you still have to get through all this first. But maybe second year, I can invite some of those folks back out and say, hey, if you're in the area, let's find a time that's mutually agreeable, and you can come talk to our students about your program and what you guys offer.
Did they base it off of your actual testing for the RRT?
Mm-hmm.
Or did you retest from them?
No,
So they based
that was
okay.
I had to obviously provide the documentation that I passed and my RRT certificate, that sort of thing. At that time, that's how they did it. But it was great. It was a great opportunity. Again, I didn't have to pay for 2 years worth of additional schooling. I paid for 1 year of schooling because they gave me the credit for having the RRT.
Yeah.
And that is a very nice thing. I used to always try to, again, I got no kickbacks from UCF. I used to always tell my students, hey, this is an opportunity, go check it out. It worked for me. And then obviously, as the years moved on, they developed a lot of online stuff, which was even better. Because to be honest and totally transparent, I commuted. I had a job here that I liked, and I didn't want to leave that job and move to Orlando. So I commuted from Jacksonville or Clay County to Orlando. The way the program was structured was 2 days a week. So I had to be down, I had to make sure I was there on Thursday and Friday, because that's when their classes were for the transfer students. And we were also with their traditional students. And I thought, well, their traditional student population is probably a lot bigger than the transfer. No, it was the exact opposite. There was probably, give or take, 40 to 50 people in the class, and maybe 15 of them were true UCF freshmen working their way up through their program. The rest of us were transfers. And God bless you. And it was very cool for me because you got to meet people from all over the state. What do you guys do down in Miami? What do you guys do over in Pensacola? How much do you guys get paid there? How much do you guys get paid over here? And it was interesting to see same job, different duties or responsibilities depending where you were, and different levels of pay. All very, very interesting and fascinating. But that's kind of just briefly my 2 cents or my story. But yeah, we would be there, again, taking a full load on Thursdays and Fridays. I would be exhausted on those days. And then I would come back to Jacksonville because I also work night shift at one of our local hospitals, and would sit there and have to turn my body around and go, okay, now I got to go work my night shift. I would always have Wednesday as my off day, try to get myself back together and do my homework or whatever studies to get ready for the next Thursday, Friday. So it was rough at the time, but I'm so glad I did it because I was able to get through that all. And that was from my baccalaureate. My master's was after I started working here. I knew respiratory, but I felt somewhat, I've never been trained as a teacher. I need some little hints or help here to how to interact better, because I know initially as a instructor, you know, just do what I say. That's why we do it this way. This is what respiratory therapists do. So do it like I'm doing it, instead of being able to explain it a little bit better. So that's why I went back to school and also got my master's in education. In case anybody asks if I'm going to get my doctorate, no. The master's took a lot of time and a lot of work and effort, and I wish I had some time to do the doctorate, but no, I'm happy where I'm at. All right, a few more here and then wrap up. So our program here, the respiratory care program, has been at FSCJ since 1975. 50 years, how about that? This is our 50th year as a program at FSCJ. Ever since, there's never been an off year. The college itself started in 1965, so FSCJ currently is going through our 60th anniversary, but this is the 50th anniversary of our program. Again, names have changed. We started as Florida Junior College, we were then Florida Community College, before we finally got to be Florida State College at Jacksonville. And since then, doing kind of a rough calculation here, we've had over 650 graduates of this program over the last 50 years. So we're proud to be here. I'm happy to say I've been affiliated with this program in some form or fashion as a student or as an instructor for over half the time this program's been in existence. So I'm proud about that. And again, I feel this is my program. I started this program. I still talk to my teachers that were there at the time. They actually recruited me over when I said, no, I'm not, I don't. So I want to be a respiratory therapist only. I want to work in the hospital. That's all I want to do. I don't want to teach. So they pulled me and recruited me into the program, which I reluctantly did on a kind of a part-time basis for a little bit, and then I fell in love with it. And I love working with you guys and helping to get you guys to where you want to be in this field and in this profession. That's it. Questions? Questions? I do have a few questions. You know from yesterday's talk how I do some questions here at the end. Yes?
So to renew your license, you just have to keep up with the CEUs?
Correct. Correct. To renew your license, you have to keep up with the CEUs. Yep.
You still have your license.
Absolutely. I'm going to be able to.
CEUs.
Yep. Unfortunately, no. I should, damn it. How much homework I do to get ready to talk to you guys? I shouldn't, but no, I don't, unfortunately. So, the same thing, you guys, when you guys graduate, will be attending or doing online or this and that to get your CEUs. I'm doing the same thing. I run into students, especially some more local conferences. You know that thing the other day I mentioned in Daytona, the Florida Society for Respiratory Care Sunshine Seminar? Guess what that offers? CEUs. I know